After hearing Sam's history, let's go through how to think about delayed puberty. And the first thing to do is let's start with a quick review of the endocrinology. So here we have our major endocrine axes. And what we're going to focus on really is going to be the hypothalamic pituitary axes as it relates to the gonadal axis. And let's review this axis first. So our pituitary will produce our follicle stimulating hormone, FSH, and our luteinizing hormone, LH. This will then have a positive effect upon both our testes and ovaries. In Sam's case, we'll be focusing on the testes. And then the respective gonads will then produce testosterone or estrogen. And then these sex hormones then feed back negatively upon our pituitary gland. And as we go through and think about puberty and delayed puberty, there are really going to be two main buckets that our diagnoses or potential diagnoses are going to fall into. We are either going to have a hypogonadotropic hypogonadism, or we're going to have a hypergonadotropic hypogonadism. So let's talk about each of these a little bit. So a hypogonadotropic hypogonadism is anything that is going to disrupt our hypothalamus or pituitary or both. And when we're asking our history when assessing delayed puberty, we'd want to make sure we had a firm history about radiation exposure, chemotherapy, malnutrition, or any congenital anomalies that may cause a central defect in our hypothalamus or pituitary. So one category within hypogonadotropic hypogonadism is damage to our hypothalamus or pituitary, but then we also can have delayed maturation of our hypothalamus or pituitary, and this is what we see with constitutional delay of puberty, where everything is intact, everything has normal functioning, it just has not matured yet. And then when we think about hypergonadotropic hypogonadism, we would be looking for anything in the history that would support normal functioning of our hypothalamus or pituitary, but we would have gonadal failure. Some examples of this would be adrenarche without menarche, as in Turner syndrome, or we could have anything that is consistent with early onset of primary gonadal failure. So there's one more axis that we need to consider when assessing delayed puberty, and this is our hypothalamic pituitary adrenal axes. And our adrenal glands, in this case, are going to respond to ACTH produced by our pituitary, which will have a positive effect on the adrenal glands, and then that will cause the release of adrenal androgens. And these adrenal androgens are going to clinically manifest themselves as sebaceous gland development. So a history question you could ask about that is the patient using deodorant? Have they developed body odor? Do they have pubic hair development? And do they have axillary hair development? So if they answer affirmative to these three questions, you can assume that the adrenal axis is most likely functioning normally. And if we are having adrenarche, axillary hair, pubic hair, and sebaceous gland development without pubarche, so no testicular enlargement, no menstruation, then this will be of clinical utility because it will say that this is not an adrenal etiology to our current presentation, and it's most likely the hypothalamic pituitary gonadal axis that is not working appropriately. So after learning this, let's relate this to Sam's case and think about his history critically. So for PERT and positives, he has short stature, but he's kind of always been short. And he also doesn't have any secondary sexual characteristics, none that are consistent with either adrenarche or pubarche, so both axes don't appear to be online currently. His parents also had late onset of puberty, so this would be supportive of something like constitutional delay of puberty, where he is just following the pattern that his parents underwent. He is also developmentally normal. That makes us think that there's less likely a congenital or other central process that would be going on causing his presentation. So with our pertinent negatives, there's no history of any radiation, chemotherapy, or chronic disease that would lead to his endocrine axes malfunctioning, and no signs of CNS pathology, no overt gonadal failure, no excessive exercise or malnutrition. So all those are very reassuring that there is not some underlying process due to either exposures or congenital anomalies that is leading to Sam's presentation. Okay, so hopefully that was a good review of Sam's history, and let's continue on with our module.